Hello everybody, I'm Robert and this is a new Revo-Spine Alliance webcast. After last week's endoscopic spine days, we are continuing our education, and in this case our online education, with Revo-Spine webcasts as usual, we have to say right now. So we are very happy to continue this with the next session, which will focus today on how to take the next step in spine endoscopy, landmarks to do a complete lateral recess decompression. So this is the topic of today, and we are very happy, and we would like to welcome our instructor of the day. So hello to Canada, hello to Montreal, hello to Dr. Jeff Golan. Hello, Dr. Golan.
Hi, thank you for having me.
Yeah, thanks. Great to have you here with us. And we are looking forward to your presentation. And as always, to our audience, you can write down your questions right into the chat. So we would start first with the presentation on the topic from Dr. Golan. He has also prepared a nice case to show you. And and afterwards we can discuss this. You can write your questions right away in the chat, and we will discuss them after the presentation. Okay, so I would say that's ready to set, and Dr. Golan, the floor is yours for the presentation. Please.
Great, thank you. I'm going to share my screen.
Mm-hmm.
You see the presentation well?
Yeah, you can see it well, yeah, thanks.
Okay, so hello again, everybody. Today's presentation will concentrate on how to do a lateral recess decompression. First, I just want to go over some very basic concepts of what full endoscopy spine surgery is. I also want to discuss when lateral recess decompression is necessary. What are some of the anatomical structures that define the lateral recess? And then when we shift towards surgery, it's important to recognize those anatomical landmarks, how to know that you're doing a complete bony decompression, and ultimately the neural decompression. Once we review these subjects and topics, I prepared a video presentation to show a full surgery edited to about 4 minutes in order to demonstrate these principles. And then we'll have some time for questions and discussion. So full endoscopic surgery is really intended as a minimal access surgery. And because the access is very minimal, there's a great reliance on intraoperative fluoroscopy. And this necessitates careful understanding and appreciation of the bony landmarks in order to have efficient surgical flow during the surgery, to be efficient with regards to movements, time, and respecting the anatomy. It's important to determine an ideal starting point for the purpose of the intervention, and in respect to that, you have to visualize the target area. So you have to understand what it is that you're targeting, in this case, the lateral recess. Where is the best starting point as seen in fluoroscopy once the patient is positioned? So first, from an anatomical point of view, in this diagram here, you can see, let me just get a pointer. So you can see here the lateral recess here on the left side, as if it's an MRI. And this nerve is flattened, and it can be flattened from either a ventral source, such as a disc protrusion or an osteophyte or herniation, or it could be flattened from a dorsal source of compression, either the subarticular ligament, which is a continuation of the yellow ligament, or it could be due to a synovial cyst that could be pushing down, or facet hypertrophy. In cases of ongoing and significant pain, the symptoms are radiculopathy, and in cases where the symptoms are brought on by standing and walking, it's really a lateral recess syndrome. This is another view of the same anatomy with a little bit more detail. Obviously, the yellow ligament attaches to the rostral and caudal lamina, but more specifically, it's important to realize and appreciate that the ligament is actually made up of two layers. The superficial layer, which you see here in a brighter yellow, attaches to the inferior articulating process or the descending facet process, the facet process that comes from the rostral lamina. It actually blends into the interspinous ligament, and this is an important item to appreciate when doing up and over decompressions. And then there's a deep layer of the ligament, which is in darker yellow. And as you can see, it inserts onto the superior articulating process or the ascending facet process that belongs to the caudal vertebra. Often where these two meet defines the medial extent of the synovial capsule. And sometimes it's very well visualized in surgery. This I found is an excellent true picture of the lateral recess. To orient you, consider that you're looking contralaterally from medial to lateral, view of the left L4-5 lateral recess. And so the 12 o'clock here is lateral, the 6 o'clock is medial, caudal is to the left, or 9 o'clock and rostral is towards the right. So the thecal sac is right here. Laterally, we have the descending facet process of L4. Underneath it is the ascending facet process of L5, and part of the ligament was already resected. And I like this image because you see the residual yellow ligament that is here, the blunt Penfield dissector, showing you the lateral recess, slightly displacing the thecal sac, and you can see the traversing root, which would be the L5 root right over here. So to complete the decompression, in this case, you would have to remove the remaining yellow ligament off the medial portion of the SAP. Generally, this area is approximately the mid-pedicle line, all the way to the tip of the SAP, which is somewhere around over here. And these are items that are visible during surgery, and before it becomes visible, we can recognize them on fluoroscopy. This is a nice true AP fluoroscopy shot of a vertebra. You can see that the arrowheads depict a clean end plate above and below the spinous process, the pedicles on either side, and here you have the lamina. On the lateral view, you can clearly see the SAP, and this is what I mean. The tip of the SAP here defines the rostral extent of the lateral recess. And the reason for this is because the deep yellow ligament only inserts up to here. Beyond that, there is no more yellow ligament. So if you're drilling the lamina up to this point, the yellow ligament should be free of its attachment to the bone. And so this is how you can ensure that you have adequately done a bone decompression rostrally in order to not have to expose the neural structures and then go back to drilling. It's a more efficient workflow. The medial and lateral extent of the lateral recess decompression is a little bit trickier. It is something that has to be evaluated one patient at a time by looking at the MRI and appreciating where the lateral recess ends and where the nerve is being impinged. But almost always, the medial portion of the descending facet process is resected, the ascending facet process is visualized, as you see here, and the yellow ligament is resected off the medial edge of the ascending facet process. Once the patient is positioned, and I find it best to position the patient on either a Wilson frame or a bed that breaks with gel rolls underneath the waist to allow for some flexion. You can see the interlaminar window opening up, and that's what the arrow is demonstrating. It's also demonstrating an equidistant between the two spinous processes so that it optimizes your ability to navigate inside proximally and distally. And this here is the inferior edge of the lamina. Lower than this, it becomes the inferior facet process. And here on the AP view, you can also appreciate the superior articulating process. So drilling will include this entire area here. When looking at it laterally, this pin that is placed is surprisingly lower than most people anticipate. In this lateral fluoroscopy, you can see the tip of the SAP, and again, that is my landmark for proximal or rostral extent of the bony resection. The superficial ligament is released by drilling the descending facet process and lamina. Often, once the ligament is freed up, it can be simply dissected further with a blunt instrument and then thinned down with either a kerrison or a sharp punch. The lamina is also drilled rostrally, as I described, to the level of the SAP. And in some cases, you also want to drill inferiorly. This is the overall flow of the drilling. So on the left is, once you define the bony landmarks, the bony anatomy, usually you start drilling at the inferior edge of the facet process, and you move rostrally towards the tip of the SAP. If you want to perform a flavectomy, you can also drill the rostral edge of the inferior lamina, right here, as you see in the second image. And this will free up the yellow ligament caudally. The midline raphe can also be dissected if you want to perform a partial laminectomy, in addition to the lateral recess decompression. Additionally, the drill can also be very useful to thin out the medial portion of the ascending facet process, which in some patients is quite thick. So thinning that out with a round burr or a diamond burr can really facilitate resection subsequently with a kerrison punch. At this point, you can see how the entire area has been well decompressed on the right versus the left. Regarding the neural decompression, once the bone is resected, the yellow ligament can usually be dissected free, as I mentioned, or it is thinned out and cut piecemeal, as I will show you in the video in a minute. The rostral edge of the caudal lamina can also be drilled with a diamond burr to release its ligamentous attachment, or that part of the ligament can also be resected with a kerrison punch, again, as I did in the video that you'll see. In some cases, additional bony resection may be needed. Perhaps laterally, the bony resection wasn't sufficient and the neural elements remain compressed. And this is something that you will visually inspect directly and deal with at the time. So it's possible to do a decompression, realize that you haven't done enough, and then perform more bony decompression as needed. To me, that's less ideal because you're going back and forth, but obviously you don't want to be overly aggressive with bony resection unless you have to. And now we'll shift to the video, which hopefully will demonstrate some of these principles, and we'll take questions at the end.
An endoscopic lateral recess decompression that I recently performed. The patient is a 63-year-old active and healthy gentleman who is one of our anesthetists and requested to have the procedure under local anesthesia. He's had sciatica for about 3 years, and the MRI revealed a significant left L5-S1 lateral recess stenosis. Here we see the MRI with both sagittal on the left and axial images on the right. He's got a disc bulge and a narrow canal, worse on the left side. Highlighted in red, we see that the lateral recess is quite stenotic. The patient is positioned prone on the Wilson frame. I proceeded to perform a left L5 and S1 medial branch block. You can see that the interlaminar window is quite narrow in this patient. I made sure to dock at the very lateral aspect of the L5 lamina, just at its junction with the descending facet process. Once the endoscope is introduced, remember we're on the left side. So 12 o'clock is medial, 6 o'clock is lateral, on the right is caudal, and on the left is rostral. Soft tissue is resected and coagulated in order to expose the underlying bony anatomy. Here we see the L5 lamina coming into view. I will then proceed to further define the inferior or distal aspect of the L5 descending facet process down to the joint. The yellow ligament is then freed in its superficial attachments, and once adequately exposed, the drill is introduced in order to thin out its medial edge. Every level is different, and in this area I needed to remove a very small amount of the descending facet process. I used the bipolar to feel around for hemostasis in order to shrink away tissues and to understand the anatomy. Here, additional layers of the ligament are required as there is a remaining shelf of the descending facet process that needs to be drilled. Once the yellow ligament is released, it facilitates entry of the drill. I use lateral fluoroscopy intermittently in order to make sure that I get rostral enough with the drilling at the level of the lamina. My landmark for this is the very proximal tip of the ascending facet process, which you can kind of see right now behind the drill. This is an important landmark as it defines the area where the lateral recess is anatomically. And so by decompressing the entire medial portion of the ascending facet process, you are sure to adequately decompress the lateral recess. A kerosene punch and the sharp punch are both used to thin out the yellow ligament and slowly gain entry through the ligament, which is then resected piecemeal. Whatever ligament remains medially is then easily resected with a kerosene punch to complete the lateral recess decompression laterally towards the remaining bone of the ascending facet process. The endoscope can be turned in order to obtain the best visualization of the anatomy. And you always want to visualize the tip of your instruments. Here, the remaining yellow ligament is lifted off the remaining lamina of S1. The bipolar is used to, once again, shrink away tissue, feel around, and with the aid of the endoscope, we can turn it and have a look to see a widely decompressed S1 root. The surgery was very well tolerated, and the patient actually went back to work 2 days later. At the 3-month mark, he continues to feel 90% of his symptoms have resolved. Thank you very much for your attention. I hope you found this case interesting and instructive.
Great. Thank you, Dr. Golan, for this very interesting presentation. Yeah, and very interesting case. I think it was nice to see your lateral recess decompression. I would suggest we move over to our questions and to our discussion. So we have some questions here from the audience. So thank you, Dr. Hossein, for your question. So Dr. Golan, he's asking, do you recommend always to drill the tip of the ascending facet in order to reach an additional decompression of the spinal canal, Dr. Golan? Do you recommend to do this?
I think it's a case-by-case situation. At L5S1, I didn't have to drill the ascending facet process so much in this case. Sometimes in the upper levels, it is essential because it could be so thick. But in general, just removing the yellow ligament off of the medial attachment is sufficient to decompress the nerve.
Okay, so you know we all learned from the textbooks, from Dr. Rutten and the others, always start at the tip of the descending facet and drill until you see the apex of the ascending facet and then go down again. So you say this is something, you would rather make this dependent on the level and what you want to do, yes?
No, that's exactly what I do as well.
Okay.
I start just as you described. For all my cases, I think it's important to visualize the same anatomy and to have the similar approach to all cases, and makes it more familiar.
Yeah. Okay, great. Thanks. The next question is, it's a little bit more advanced. What about going then on the other side? What about going over the top decompression? Dr. Name is asking, do you have any recommendations you give our participants that are maybe at the same level now, that say, okay, I'm doing recess decompression. What about going the next step, going over the top? What do you recommend them?
Well, I start the surgery in the exact same way. When I'm planning to go to the contralateral side, I make sure that I decompress the undersurface of the spinous process and lamina so that I see the yellow ligament getting freed up. And then I know that I've reached the rostral extent of the yellow ligament and the decompression that I want to achieve. The next step is to identify and separate the superficial ligament from the interspinal ligament. You can do that with the punch, and then you follow the bone on the contralateral side. So you see the lamina as it continues across to the other side, and then down again. You're on the superficial lamina, the descending facet process on the opposite side. And I then turn my endoscope so that I'm seeing it from the top down. I find that is a very nice view so that I can see the yellow ligament medially and I see the bone laterally. And then I can drill the interface in a very protected way. And then that releases the yellow ligament. I then take, some people do this all the way down to the tip of the joint. I prefer to do it in stages. So I drill a little bit, and then I resect yellow ligament with the punch, and then I drill a little bit more. And I find that this assures that I do just enough decompression without doing too much. And then at the end, Kerrison punch is a very useful tool to complete the resection of the yellow ligament on the contralateral side. And I like to visualize the traversing route on the opposite side.
Yeah.
So that takes an additional time, obviously. It's more time consuming, but it all starts with the lateral recess decompression of the ipsilateral side and then moving to the opposite side.
Yeah, great. And that's also the topic of today. So we stay on the one side, we don't go to the other side. But just a question to Golan. I mean, we've seen this also in your presentations, and this is the same what you mentioned. There is you like apparently to rotate the endoscope, and don't you get lost because of that? I mean, the view is of course very nice. Yeah, you can see the recess very nicely, and it helps you a lot. But is there any recommendation you can give, or how do you know where is now caudal cranial? Is it something maybe you wouldn't recommend to a beginner, or?
Well, I think it's essential to be able to navigate like that. For example, seeing exactly the tip of the drill, and seeing sometimes you want to coagulate a bleeder. I think changing the perspective of what it is that you're doing gives you a great advantage. And that to me is one of the greatest advantages of endoscopy as opposed to tubular microscopic decompressions. The ability to navigate and visualize the anatomy so precisely is a great tool.
Okay.
And one that you don't get lost because you learn how to kind of your fingers and your hands know what your eyes are looking at, and you adapt very quickly. The one thing that is tricky sometimes is to, you're looking at it from the side and you're drilling in one direction. That takes a little bit of getting used to, but like everything else, once you get used to it, it's a tremendous help.
Yeah. Great, and I imagine also to finalize this question, the reply of this question is, if you go on the other side, you take also maybe a different set. Do you take the stenosis set in that case? Like if you do a bilateral decompression, I imagine, yeah. And why?
Yeah, I find it's easier. The drills are bigger, and I have a bigger view of the anatomy. So I prefer the stenosis set for those cases.
Yeah, but if you stay on your side, if you do a recess decompression, what do you use? What set do you use in that case? Do you use also
it really depends on what's available.
Okay.
If I know that I have an underlying disc that I want to explore, then I use the interlaminar set.
Okay.
If I know that there's no disc at all and it's just a straight up hypertrophied ligament or facet that I want to take down, then I would just use the stenosis set. Okay.
Great. Thanks so far. So yeah, we discussed this, Dr. Golan, initially also before the webcast. We are all very very impressed by the learning curve you made and how fast you overcame the learning curve actually, because it's been not a long time that we've been in touch together, and we accompanied you during your learning curve as well, of course, with workshops. And and again, so we are impressed how fast you got to this level of doing now. We're talking also about cervical spine, endoscopic spine. So this is a very advanced level where you got quite quickly. Can you tell us what was the key of that? Is there any recommendation you can give to our users? How can they get also to that level so fast? Is this because you have a lot of cases, or why is that? Or you're Superman?
No, I'm not Superman. I think that it starts by paying attention to the details in the anatomy and learning how to recognize the anatomy. So before I started using endoscopy, when I was learning about endoscopy, it took about 9 to 12 months before really getting to do any endoscopy cases. So during that year, I use the tubes as I've done. I've done about 1,500 cases to 2,000 cases of the tubular microscopic decompressions, up and over, lateral recess, all sorts of cases. And so I was getting familiar with the anatomy. So I was performing the surgeries as if it was endoscopy. So even though it wasn't using endoscopy, I was using different tools. I was still trying to expose the anatomy in a similar fashion. So in fact, I've done many more cases in that same way than just using endoscopy. And then once I got the endoscopy tools, it was a matter of getting familiar with how to use them, how to position, how to navigate, when to use one type of rongeur versus another, how to expose the anatomy. And then once I was able to do that, the rest is basically practice and getting better. I'm still very much in my learning curve. I'm progressing well, but there are things that I still have to kind of get the courage to do, like redo operations. I still do with a microscope because of the comfort level, and some transforaminal cases I find challenging, and so there's a long way to go, but it's certainly a process. But for me, it's been very straightforward to transition from microscopic interlaminar decompressions to endoscopic decompressions because I've had so much experience with it.
Okay, so let's say that tubular surgery helped you as well, and you would recommend maybe to start with that before going into endoscopy, if I would resume it like that, if I'm not mistaken. So you, Dr. Golan, you spoke already about the advantages for you as a surgeon during the surgery, obviously having a better view because you have a look like inside the patient, and you can expose the anatomy very well. This is of course something that is pretty advantageous, let's say, for you. What about the patient? What is for you the big benefit for the patient, or is there any for you patients for that?
Yes, there is. There are a couple of benefits. Number one, I find that the visualization I get from the decompression is superior with endoscopy than using the microscope. I can really follow the tract of the nerve and assure that I've done enough of a decompression. The other big element, and it may be the most important element, is twofold. Number one, patients don't have any pain post-op. So I haven't ordered any opioids for patients after surgery. They literally leave the surgical clinic 2 hours after surgery with Tylenol and anti-inflammatory medication, and that's it. And lastly, I haven't had any epidural hematomas or any significant pain that occurs 2, 3, 4 days after surgery, which occurred at least about 2 out of 10 patients I've had using microscopic decompression would have significant post-op pain that I would attribute to probably a small hematoma in the area. I haven't had, obviously, to decompress that many, but it's still something that prevented the patients from progressing in their recovery, the additional week or two of severe pain. I haven't had that happen except the one case that I presented over the weekend. Otherwise, I've had very good post-op recovery, fast recovery, and people going back to work within days. So those are the immediate advantages to my patients.
Yeah, sounds great. I mean, if our patient sounds really great as an advantage or as advantages for them, of course. Now we have a question we got by email on the education mail, so thank you for that. It's also, we got this question last week as well. It's about the recess decompression, about the pathology, let's say, and the access that you would recommend. I mean, we've seen this in your presentation and also in your case. Obviously, you would opt, if I'm not mistaken, always for the interlaminar choice. What about the transforaminal approach? Is it appropriate for that pathology in your opinion as well in sometimes? If yes, in what pathology exactly, or not at all, and why?
So performing a lateral recess decompression from a transforaminal approach is actually quite challenging. I think it's a higher level of difficulty because you're exposing the anatomy from an unfamiliar point of view. And it is certainly possible. It requires a lot of drilling and to position the entry into the foramen or the superior articulating process in such a way to optimize the area of the lateral recess that you need to decompress. It is an advanced procedure, and in some levels it's impossible. So at L5S1, it's probably close to impossible to do a good job because of the limitation to the access, the iliac crest, and the verticality of what is required to gain a safe entry into the foramen. At other levels, it should be possible, but it is quite an advanced procedure, one that probably would lend itself well to redo cases and things like that. So it's doable. I haven't done any of those cases yet. I'm not quite familiar enough with the anatomy to do that, but it's something that I look forward to gaining comfort with in the future.
Yeah, great, thanks. And I heard also surgeons say that, yeah, if you might do this from transforaminal, it's challenging, but not only challenging, but they said you would need to destroy the whole facet in order to do that, which is maybe not the goal of endoscopy. Dr. Golan, let us continue your journey on the learning curve. So what is next for you? So you showed us very complex cases, or let's say nice cases for recess stenosis. Apparently you do also already complete canal, bilateral decompressions on the lumbar part. Yeah. Is there a next objective that you're looking at in endoscopy?
Yeah. So in my kind of a toolbox of endoscopy procedures, I'm comfortable with foraminal disc herniations and easy posterolateral disc herniations from a transforaminal approach, but I still need to gain comfort with foraminal stenosis, so drilling the foramen. That's something that is challenging. I also want to start to do cervical laminoforaminotomies. I'm very comfortable doing those with a microscope, and I want to transition to doing those with endoscopy. So I'm going to be joining you for one of the master's courses to just get familiar with the workflow and some of the steps that you guys recommend, and then just start to do the cases.
Great, thanks. Yeah, looking forward to that. Looking forward to meeting you at one of our master courses, of course. I think we have so far no further questions, and I think it was a very nice discussion. Thank you, Dr. Golan. Yeah, and for the participants, thanks for participating, and thanks for your questions. If there's anything else you want to ask us, please write us an email to education@revospine.com. Of course, if you want to join one of our courses as well, you can ask us. We have everyday training courses ongoing around the world, and thanks to the advancements we have, we can now offer more and more courses. Yes, and that's it. Thank you for joining. Thank you, Dr. Golan. It was very nice.
Thank you.
To see to have your experience and to share it with us. Thank you to all of you. Thank you. Goodbye.